Welcome to Dental Business RX. Practice success in 30 minutes or less.
Thank you for calling ABC Dental.
We all know that improving case acceptance is a good thing, but I think its importance tends to be undervalued. It tends to become just one more thing on the list of many things that someone might want to fix about their dental practice. You know, it's improve case acceptance, fix my schedule, develop job descriptions, etc. But in reality, ramping up case acceptance or your case acceptance percentage is overwhelmingly the most immediate and effective catalyst for sustained practice growth. It raises collections and profitability. It, believe it or not, increases new patient referrals. It results in higher career satisfaction for the doctor. They're doing the type of treatment they enjoy doing. And most importantly, it improves the health of your patient base. More patients are getting the treatment that they need. It's truly a win-win scenario for you, your practice, and your patients. So if you'd like to improve in this area, where do you start, and how should this sales process in your practice look? And that's what I want to talk about in this week's and next week's episode. Yes, this is a two-parter again of Dental Business RX, specifically how to strengthen and streamline the treatment presentation and acceptance process in your practice. My name is Jeff Bloomberg, and I'm your host. And what I'm going to be covering with you is what we actually teach MGE clients, how we teach them, the process we teach them to improve case acceptance in their dental practice. Now, being that this is a limited time podcast, normally we're teaching this in a seminar format over hours and hours, I'm going to be focusing more on the how of the various things I'm going to be telling you. How do you do this? As opposed to the why, just because of time limitations. But I'm going to show you the how. I'm a big believer in that. Rather than just telling you to improve your case acceptance, I'd like to give you ideas of how to actually do it. And you'll notice I've touched on some of the things that I'm covering in this episode in prior episodes. But what we're going to be doing in this one is taking this and a bunch more that you haven't heard before and putting it all together. So the way I'm structuring this episode is we're first going to look at the big picture of, what creates case acceptance in a practice. What are the key components of it? And then we're going to break down the process step by step. We're going to go through the whole sales process, beginning with a new patient initial, new patient initial exam to cover how this should work and where it might go wrong. The idea is you could listen to this episode, you could even listen to it with your team and sort of look at how the process works in your practice and check it off against some of the things I'm going to be talking about. Now, again, like all of our episodes, we're big believers in that everybody is responsible for their own condition. You have to You're the boss of your practice. You're the owner. So you have to decide how you're going to apply this to this practice and make sure that you're in conformance with what you're supposed to be in conformance with and your own better judgment when you're working in your office. So now the first thing to look at with regards to improving case acceptance is there's really two big components. There's the process itself, the organizational aspect of it, and then there's actual skill in what we might call, I know we don't love this word, sales skill. So there's skill and there's the process itself. And both of these things need to work if you want to maximize case acceptance. But, you can't do one without the other. But believe it or not, if the process is in place, you're going to have more success if the process is in place and your skill is not great than if your skill is great and you have no process. Let me explain. So skill is how good of a closer am I? If I sit down with somebody, how good am I at communicating? How good am I at removing objections so that the person proceeds with whatever it is that I'm attempting to sell them? That's skill. Then there's the process. How many prospects do I actually have to sell to? How much time do I have to sell to them? Do I have a long time that I'm waiting in between people that I'm seeing? In other words, I have very few people to present to. So that's the process. So if we take a look at this, and I've said this before, you could have a mediocre salesperson and an excellent salesperson. Let's say the excellent salesperson closes 80% of the people they talk to, and the mediocre one closes 30%. All right, but now this sales process, requires a half hour to do effectively. So if I take 10 prospects, each for a half hour, and I put the great salesperson versus the mediocre salesperson up against them, I'm going to get 8 closes with the great salesperson because they close 80%, and the mediocre one is going to close 3. But now let's say that I don't have a good sales process in place for the great salesperson. They only have 5 minutes with each prospect, and they only have 5 prospects instead of 10. Well, they may close 1 at that point. Meanwhile, if I leave the process intact for my mediocre salesperson, they still close 3. That's what I mean by the process having something to do with this. Time plays into sales as well as a number of, and just sheer volume, sales opportunities. So these are 2 areas you want to improve in. What I'm going to be talking about today is the process. How does this whole process work? But that doesn't absolve you if you're having trouble selling from increasing your skill. You do want to improve your skill because then you're going to maximize the opportunities that you're actually being presented with. So let's start by looking at the big picture. What is the recipe for sales? Well, it's really 4 basic things. 1, you need people in a dental practice. We're looking at sales in a dental practice, or case acceptance, in a dental practice. You need patients who need treatment. You have to have patients who need treatment. Sort of a, no duh. Now, where do those opportunities come from? That might be new patients, whether those are initials, emergency patients, second opinions, etc. And it would be patients of record. Recall. And, we've said this before, but 50% of your revenue should be coming from patients of record. And I don't mean the hygiene revenues. That's something completely different, the revenues produced by your hygiene department. I'm talking about if you look at the doctor's production, 50% of the doctor's production should be coming from patients of record. And without going off on a diatribe on this, because again, I'm supposed to do this in 30 minutes or less. I'm not always great at that. But one of the big problems when you have a practice with an ineffectual recall program is you'll have a doctor, they've been at 4 days of hygiene for years, 4 days a week. And they go, well, all of my patients are clean. They don't need any treatment. Well, that's because the upper tier of your patient base, you're going to have a certain percentage of your patient base, which are just great compliant patients. Okay. So these patients show up all the time. So these patients who show up all the time, of course, are never going to miss recall appointments. They also do the treatment that you recommend. So those are the people who are those 4 days of hygiene, because, you should be expanding your days of hygiene every year that you exist because you're adding more and more patients to the practice, right? So then what's happening is all the patients who you're not calling back in to fill up your hygiene program are the ones that actually need treatment and that you're not seeing, okay? So that's why you might think that your entire patient base has, no treatment to do. It's a complete fallacy. If you take a look at your incomplete treatment list, you'll find tons of it. It's just you'll find that these patients aren't showing up regularly because no one's calling them in. Your hygiene department isn't expanding. So we've got those 2 areas, patients who need treatment, which are new patients, and patients of record. Patients of record should make 50% of the doctor's production. All right, so now we have to diagnose this treatment, or in the case of patients of record, you might need to update the diagnosis if it's been a while since you've seen them. And then assuming the treatment's been diagnosed, we have to present this treatment. Now, in order to present this treatment, you have to have time built into the schedule to actually present it, which, most doctors have time built in for treatment, actually doing the treatment, and they have time built in to diagnose treatment, on exam, but they don't have time built in to sell, to actually present the treatment plan. And it really is something that you need to do. I'm going to talk about it in this episode a bit, but you need to build time into the schedule to sell. Now, assuming you've got the time to sell and you're presenting the treatment and you have a process for your sales process in your practice, the treatment gets accepted and paid for, scheduled, done, and back on recall. That's the sales process. All right, it's real simple. So let's walk through this process with a new patient initial. We'll cover all the different team members involved because everybody has their part, right? And it's like anything. If you have, say you had an assembly line where you were building stuffed animals, okay? And everybody has a certain job on this assembly line. Somebody sews the stuffed animals, somebody sews the eyes on the stuffed animal, someone stuffs it, someone puts the ears on, and someone does quality control, right? Everybody has their part. Well, if one person doesn't do their job on this assembly line, well, then you end up with no stuffed animal. That's generally how it works, right? So someone doesn't stuff it, you don't have a stuffed teddy bear at the end of the assembly line. Or someone doesn't sew the eyes on, you don't have a stuffed teddy bear. Either way, you don't have a completed object that you're supposed to bring to market and sell if one person doesn't do their job. So we're going to go over the different team members involved with this process, and it's important that each and every team member does their job because the level at which they do their job is going to have a large amount of bearing on the overall outcome of the process. All right, so where does the sales process begin in a practice with a new patient? Well, it starts with the receptionist, the person answering the phone. And the biggest problem you run into in this area normally are the patients that you never see. You know, we've mentioned in prior episodes that the average conversion rate for a new patient call, meaning calls that come in, the number of patients out of 100 phone calls, how many actually end up on your schedule in the average dental practice in North America is 23. So 100 patients call in, 23 convert, meaning they actually show up. So, you know, the problem really there isn't the 23 that show up. It's the, 77 who didn't. Okay. And this obviously will affect case acceptance because there's just less opportunities at that point. It's also something that's going to affect overall growth and the amount of money you're spending on marketing and so on. And we went over this at length in episodes 3, episode 48 and episode 70. Episode 3, we talked about dental reception. Then we talked a little bit more about reception in episode 48 with Sabri. We had Sabri on. Then we had an episode recently, episode 70 with Jeff Santone, where we kind of gave you a 10-point checklist that you can use to grade your receptionist. As a matter of fact, I'll put these things up as downloads if you want them. We have a new patient intake form, a call log, and a 10-point grading sheet that you can download in your practice, to grade your receptionist. So assuming your receptionist is good, meaning they can convert 50, 60% of the calls coming in, which is where you want to live. 50, 60% or higher is where you want to live. And this is all calls, by the way. This isn't just somebody who calls saying, I want to get my teeth cleaned. This is shopper calls. This is second opinion calls. This is all kinds of calls. Every call coming in is a valid new patient, a prospective new patient for your practice. And if they're handled properly, they should show up on the schedule. The other thing that can mess this area up is availability. So if I call into your practice, let's say I've just moved to your area and, I just moved in the area and I'm looking for a dentist. I want to get my teeth cleaned. And I call and I when can I come in? And your first available appointment for a new patient initial is, 5 weeks, 6 weeks from now. That's a problem. Because for a number of reasons. Unless I'm referred to your practice, I have 0 degree of loyalty to your business. You and I have no connection. So you're amongst the other 1,200 dentists within a 20-mile radius of my house. So if I call your office, your ad does its job and gets me to call. It did its job, folks. And I call, and I'm going to have to wait 5, 6 weeks to come in. I'm either A, I might schedule, or B, I'm not going to schedule, or C, I might schedule, then call another office and cancel with you. So the moral of this is if you want to have a free-flowing line with regards to new patient acquisition, if you're really going after new patients, and a lot of doctors are, they're marketing for them. You have pay-per-click, you have Facebook ads, you have mailers, newsletters, etc. If you're going to go after new patients, you have to actually be able to see them in a timely manner. You should look at this from a consumer's viewpoint for a second. And this is sometimes tough, but from a marketing perspective, you have to do this. You have to be able to assume, what would a patient think if they called my practice? This is just something useful anyway, by the way. Walk into your practice as if you've never been there before and, see what it looks like. You might find things, stacks of folders that are sitting behind the front desk that everybody gets numb to seeing, because they've been there every day. People are putting coffee cups on them. But, because you've been there every day, you sort of get immune to looking at them. But walk in there with a fresh set of eyes and look around. But you want to look at this from the perspective of a new patient. So a new patient calls your office, or let's say a consumer. You call a store and you want to buy something. And several stores in town have this item potentially, but you've called this store and they're not going to have it for 3 weeks. Well, if you really want it now, you're probably going to pick up the phone and call another store and go get it. Well, the same thing applies with your marketing responses to for new patients. Again, they have no loyalty to you unless this is a referral or someone's spouse. They don't know you. You're maybe close to their house, but I guarantee you someone else is close as well unless you're somewhere out in a super rural area. So you have to be able to see new patients within 1 to 3 days, ideally 24 hours, if not 24 to 72 hours. Now, a qualifier on this, if let's say I call your office and I go, yeah, I'd like to come in and have my teeth cleaned. I'm new to the area. And you go, good. Well, we have an opening tomorrow at 11. Oh, I can't make it at 11. Okay, we have an opening the following day at 4. Yeah, I can't come in at 4. As a matter of fact, I can't come in for 2 weeks. Well, then fine. Schedule me for 2 weeks. That's on me. That's not on you. I'm insisting on 2 weeks. But if I call and I say, yeah, I'd like to come in. Oh, we don't have anything for the next 5 or 6 weeks. That's on you. And this will for lack of a better word, torpedo your sales line and pretty much make your marketing efforts wasted. Now, how do you open up time? You start blocking new patient time out on the schedule. You might have a policy that, because, I'm going to get into this a little bit, but, for new patient initials, some offices have them go on the doctor's schedule. Some offices have them go on the hygiene schedule. I'll survey seminars and I'll have people raise hands, how many people put them on the hygiene schedule, how many people put on the doctor's schedule. And it's almost a 50-50 split. There is no right or wrong here, folks. You have to do what you want to do. This is whatever's real to you. You're the doctor. You have to decide how you want it done in your practice. Ultimately, with a new patient initial, the doctor is going to do an exam. No one else is doing this examination, and that's the bottom line. So how you bring them in is up to you. But what I've seen some offices do, if they're just running out of hygiene blocks, let's say they had hygiene blocks for new patients and they're full, they might throw it on the doctor's schedule. When they find some time to do it, because at least the patient gets seen and the patient isn't waiting. Or you might be artificially suppressing the fact that you actually need to add more hygiene days, in which case you do that. But bottom line, you want to get them in within 1 to 3 days. Critical. Now, so patient calls in, you handle them well, gave you the downloads for that and also the other episodes you can listen to. And then you put them on the schedule. Now, in some offices, you might have somebody answering the phone and you might have somebody scheduling patients. In a lot of offices, they call that person the quote-unquote receptionist. In a larger practice, you might have a receptionist and a schedule coordinator. It all depends on the amount of traffic that you're getting. If you need this, really depends on how busy you are. And this is something that you want to keep a consistent eye on. If you find, this is another reason I'd be listening to my incoming phone calls. Whoever's scheduling patients, especially new patients, if I listen to those calls and I see them putting the patient on hold a lot, not because they don't know what to say, but, another patient's in front of them or another call's coming in or something like this, or they sound flustered or hurried because they've got 10 other things going on, then it's time to make a change. And by change, I don't mean anything with the person answering the phone. They're probably doing a great job. It means I might need somebody else up there. Because, again, you have to look at this from the consumer's viewpoint. Consumer calls in, and they're being put on hold 5 times because the person at the front sounds overly busy and frustrated that they're not able to help me as quickly as they'd like. That's going to lose you patients. So I wouldn't want to be put in that situation. That's where corporate has gotten smart about this. And in a lot of cases, when you call a corporate office, you're calling a call center. Maybe not an outgoing call center, but an incoming call center. So the person answering your call has nothing else going on. They're just scheduling you. So you would like to engender, to the best of your ability, that same setup when a new patient calls your practice. Ideally, it should be an uninterrupted call, and the person I'm talking to should be able to answer all my questions. So if you're a bigger office, it might be somebody answers the phone and routes me to somebody to schedule, and my time on hold is, 10 seconds, and the person who picks up the phone spends an uninterrupted, 5 to 8 minutes getting all of my information and scheduling me. Okay. But now it's a new patient initial. So what are we scheduling me for? We're putting me on the hygiene schedule or on the doctor's schedule. In any event, I'm getting a doctor exam. Up to you how you guys want to schedule this. So let's move on to the exam process. Now, we're going to talk about the exam here. I'm not going to get into the clinical aspects of how you do an exam. That is up to you. You're the doctor. I would recommend that if you have a procedure you follow or a sequence you follow, when you come in the room and do your exam and charting and whatnot, I would write it up if I were you as a little policy in case you end up bringing on an associate or you have some doctor covering for you so that you have a degree of consistency. You should also write up, let's say you're seeing these patients on hygiene, or even if your assistant is doing work with them before you actually meet the patient and taking x-rays and whatnot, I would write up what you expect. So again, if I bring in a new hygienist and they're going to be seeing new patients, they know exactly what's expected in the practice. So I don't have it where, hygienist A does a great job and hygienist B does a terrible job or kind of just decides what they want to do on their own. Because remember, if you don't provide guidelines, people like guidelines, they invent their own. Problem is, you may not like them. So let's get to where the actual exam's occurring. The doctor is walking into the room to do the exam. Now, most new patient initials, again, this is by survey, just surveying new clients when they come to MGE. The average time scheduled is usually anywhere from an hour to an hour and 10 minutes. Now, the hour and 10 is more post-COVID to allow more time for, things to get done in the practice and room turnover. But the average is about an hour. So usually what that does, let's say this patient's in hygiene. So the hygienist is doing their perioprobing, their charting, they're getting other information from the patient. Usually that's going to leave the doctor about 15 to 20 minutes for the exam process. All right. So you walk in, you build rapport with the patient, you meet them, you look in their mouth, you're looking at their x-rays. Usually, and again, look, everybody's different, but the average doctor is going to take about 15 minutes doing all of this, which leaves 15 minutes into the exam, they have a pretty good idea of what treatment this patient is going to need. So that leaves you about 5 minutes to present the treatment, which you don't want to do, which I'll explain in a second. But let's talk about during this exam process, a couple things. These are just tips or ideas. Again, this has no bearing on what you do clinically. I'm just going to give you some just people handling skills tips here to make this an easier process and improve your close rate when you actually end up presenting the treatment. So a few things. One, we don't want to ever leave this new patient alone. Obviously, if there's a hygienist in the room, they're not alone, right? But you don't want them just sitting there cooling their jets with nobody else in the room. Okay. The other thing is when you're doing the exam or going over things in the patient's mouth, use terminology that they would find accessible and that they understand. All right. And you wouldn't even necessarily get into this during the exam. You're probably going to get into this more in the treatment presentation, but we're not talking about periapical radiolucencies. We're not talking about abscesses. That's an infection. We're using words that, meaning say infection. We're using words that are accessible to the patient. So we're going to use terminology that the average person is going to understand, not dental terms. Dental terms, the average person is not going to. There's a big why behind this. I'm not going to get into it so much, but I can tell you it's extremely important. I'm going to use, because on the one hand, if I'm using terminology that the patient doesn't understand, this is on the buccal surface of the tooth, blah, blah, blah. Usually people won't ask questions about it and they may get a bit confused. People don't want to ask questions because they don't want to look stupid. And that's not the effect I want to create with a patient. All right. So we're going to avoid heavy terminology, number one. Number two, I'd suggest that during your examination process, you avoid specific procedural terms. Let's say you're charting with your dental assistant, right? We're going to need a root canal here on number 3. All right. We're going to need a crown on number 5. Well, you're using procedural terms that the patient probably has heard before. And remember, we're doing this during the exam. So here's the problem with that. The second you mention a procedural term, you have begun the sales process. Believe it or not, the second you say root canal, the second you say implant, the second you say crown, you have begun the sales process. And ideally, we don't want to begin the sales process unless we're in a position to finish the sales process, which you're not during an exam. So you're better off using abbreviations. So you can tell the patient, I'm going to use a bunch of abbreviations. So it's RCT and CR or whatever you want to. You could have your own abbreviation system that everybody in the office knows. And you tell the patient, your teeth have numbers. You can tell them a little bit about that. And I'm going to be using different abbreviations as I go through your mouth. Don't worry about what they mean. I'll explain them when I go over what I found. So, you're going to hear a bunch of numbers and weird terminology for a minute, but don't worry about it. And then you just roll off with your dental assistant so you can get your charting done and start to develop a treatment plan. And we're going to go over those procedures. We'll start mentioning the actual words for those procedures when we actually present it. Obviously, during the exam, you want to make sure that you have a good handle on the patient's chief complaint. I say this because, I've seen cases where people ignore it and that kind of upsets the patient. You want to make sure that, you got to do whatever else you got to do as well clinically, but you also want to make sure that you're encompassing their chief complaint and whatever it is you're sorting out. And then the most important thing you're going to want to do during this exam process, this is where you're getting to know the patient. All right. This is where you're getting to know them. Who is this person? What is their attitude toward dentistry? What's their attitude? What have prior dental experiences been like? What do they want to get solved today by coming into the practice? Is there anything that they want to let you know about that they would like to have fixed? Why? Because we're trying to get an idea of what this patient's mindset is. All right. And, just because their mindset isn't the ideal mindset doesn't necessarily mean that's a bad thing. So look, ideally you'd want somebody who comes in and says, I haven't been to the dentist in 3-4 years, 5 years, and I know I need a lot of work and, I've been saving up for it and I'm ready to start it right away. And I'm so excited to be here. Not everybody's going to be like that. You're going to have patients who say, well, look, I'm a strong believer in dental insurance and I don't want to pay a penny more than my dental insurance is going to pay. Or, I hate going to the dentist and the least amount of dental work I can get done, the better. Or, I know I've lost a tooth. I don't care if I lose my teeth. I'll get dentures one day. People are different. Everybody is going to have an individual response. My viewpoint on this is you're gathering data to develop, who is this person? what's their attitude toward dentistry? What's their attitude towards their oral health? Because then it gives me an idea of how much time am I going to have to spend in order to get them to where I want them to get, where they actually really care about their teeth and want to fix whatever problems I find. Might take more time. You might have more work to do, but that's fine. It's a challenge. It's more, look at it more from a fun perspective. You're just getting an idea of who is this person and what are their thoughts. And one thing I'll mention here that's a little bit important is, and I think I've talked about this before. I know I've done it on videos here, or at least in seminars. I did an informal survey of bad reviews for dental practices. I just randomly pulled up dental practices Google reviews, and I counted the negative reviews. And I found that at least 30% of negative dental reviews related back to the treatment planning and presentation process. Meaning you'll see these reviews that look like, I went to this office to get my teeth cleaned and they told me I needed $10,000 worth of work. My last dentist never said I needed that, blah, 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 blah. Okay. So this is the other thing that you're doing when you're meeting this new patient for the first time is you're finding out what their thoughts are on their oral health, because you're doing your exam, let's say, and you find all kinds of problems. But when you talk to them, they tell you how they were the superstar patient at their last dentist in the other state they just moved from. Yeah, my doctor never told me I needed any work done, said I took great care of my teeth, said he wanted a picture of me on the wall as his ideal patient. Yet what you're looking at is they need $8,000 to $10,000 worth of dental work. They got a little bit of a mess going in their mouth. Well, if you don't say anything or do anything, you're going to have a problem when it comes time to that treatment presentation, because they're going to think that, what treatment, and you're going to lay out all this treatment, and they may think, well, you're scamming them or you're lying to them, or they're going to want to go somewhere else. And, the not necessarily the worst case scenario, but not the best case scenario, they're going to leave a negative review about you, about how you just, they came there just wanting their teeth cleaned and you told them they needed all this work. So how do we get around this? Ideally, you would want to foreshadow this a little bit before the actual treatment presentation. So how might this look? Well, let's say you're doing your charting and you notice some things and they've told you how they have great oral health. Well, most people have an intraoral camera. You might want to start showing them some things or saying some things to them. Hey, have you noticed that the back, the cusp on this tooth is missing? No, which tooth? The one in the back, bottom left side of your mouth. Well, you can run your tongue over it. Look, see? Or here in the mirror. Wow, I never noticed that was missing before. Yeah, and do you see this dark spot here on the side of your tooth? It's pretty big. You notice it's getting a little soft? Well, I never saw that before. You can pull it up on the intraoral camera while you're doing the exam too. What are we doing when we do that? We're giving the patient the idea something may be wrong. Something may be wrong that is going to have to be addressed. We're not just coming in with this earth-shattering meteor of bad news when we sit down to present treatment. We're breaking it to them gently so that when it comes time to go over their treatment plan, they at least have an idea in their mind that they actually may need some dental treatment. I've talked about this with regards to personnel too before. I think the worst thing you can do to somebody, unless they do something horribly egregious, is just to fire them without any warning of any kind whatsoever. They have one little mess up and you fire them. I believe in giving people chances, again, unless what they did was super egregious. But, you tell them, look, if you don't change this pattern of behavior, we're going to have a problem. And then you do it again. Well, look, if we don't correct this, I'm going to have to replace you. Then they do it again and you go, look, okay, I'm going to have to replace you now. I'm sorry, it's not working out, or whatever you say. It doesn't come as this huge, devastating surprise. I believe in the same thing. You could apply this during the exam process without getting into what it is or why it is or whatever, so that when you bring them back, it doesn't come as some humongous shock. All right, so you've finished your examination, let's say. You've done, again, clinically, you're going to do whatever you do. There's various steps. I would catalog it if I were you, so it's some knowledge you can pass on to other doctors when you bring them into the practice, and they do it the way that you like it, but you've finished your examination. Now we're up to the point where we need to work up the treatment plan, which shouldn't really take that long. Well, it depends, I guess. And we're going to have to present the treatment. So the question is, are we presenting the treatment now, or are we bringing the patient back? Well, let's take the average scenario. You have done your exam. You had 20 minutes. You've spent 15 minutes doing your exam, all right, and charting and whatnot, and you have 5 minutes left in this 1 hour new patient initial appointment. And let's say this patient needs, $10,000 to $12,000 worth of dental work. Well, most likely, and this is where a lot of offices get it wrong, you should not present at that point. You have 5 minutes. That is not enough time to close this case. So this is where we have to decide how we're going to handle this. Now, what a lot of, I've seen other consultants recommend, and I'm not knocking other consultants, I just disagree with this viewpoint, is the solution to this is to have a treatment coordinator present all of the treatment. Now, I have a problem with this for a couple reasons. Number one, I mean, in the long run, I don't, but let me explain to you my reasoning on this. Is if you're the doctor owner, you own this business, which if you own a business, anything that you are not able to do makes you that much less effective. So if I have a business, let's say, where I sell furniture and I don't know how to sell furniture, right? I know how to stock furniture and inventory furniture and order furniture and how to pay my bills and do basic accounting, whatever, but I can't actually sell furniture. Well, I'm at the mercy of my sales force at that point. Also, because I can't do it, I'm going to have trouble correcting salespeople when they can't sell. And I personally don't like living like that. I need to be able to, maybe I'm not going to do it as good as my salespeople, but I need to be able to do it. So you own a business, you have to be able to present and sell your services. It's an ability that you need to have, okay? The other factor is the person a patient is most likely to listen to is the doctor. That's who a patient's most likely to listen to. If you ask your staff, if you don't believe me, they are. A patient's going to listen to the doctor and take what the doctor says with a little bit more gravity than anyone else in the practice. It's just the way this thing's structured. So if the doctor presents treatment and tells the patient what they need, and if they spend time, they build in a little bit of time to actually answer their questions or whatever, that's very impressive to a patient, and I think that that's something that should be done. Now, we've had clients that have worked their way up to the point where they're not necessarily presenting all the treatment anymore, and that's fine, but if they had to, they could. So you need to know how to do this. This is very important. But again, going back to our scenario, you got 5 minutes left to present this case. That's not enough time. So in that case, you're going to have to bring this patient back. So let's talk about time to sell, okay? Because we're not even at the sales, presentation yet, but we need to make sure that we have a proper sales presentation or sales opportunity. So let's start by defining what that might look like. So a couple things about this. Let's say it's a $5,000 case or a $6,000 case. Well, let's say this patient that we're talking to makes $60,000 a year. Well, we're going to be presenting a treatment plan where we're asking them for 1/10 of their annual salary. So, do a thought experiment for a minute and look at how much you made last year and, how long would it take somebody to convince you to spend 1/10 of that on a particular product or service? It would probably take more than 5 minutes. So a proper sales presentation would be an adequate amount of time to explain what's needed, why it's needed, what are the consequences of not doing it, and have time to answer all of a person's question. Now, you could probably have a default sales presentation time or what we'd call a consult time. That's the way in your practice, the way you set things up. Maybe it's 20 minutes or 30 minutes. That's the average consult time in your practice. And that's the default amount of time that people schedule it for or your front desk schedules it for, unless you make an adjustment. If it's a bigger case like an FMR, you might want an hour. But the default, let's say, is a half hour. That's built into your schedule. Half hour is a consult. And, I know when you hear the term consult, you might think of FMR cases or humongous cases. Those are consults, right? Not necessarily. Going back to what I just said, if you're asking somebody to spend 1/10 of their yearly income, that's probably going to be a conversation. So, rather than spending 5 minutes and blowing it, why don't I spend a half hour and get the person to agree? It's better for, the practice, for me as the doctor. I'm going to collect more. But again, most importantly, that patient's going to get the treatment that they actually need. And it really does strike patients. You will be shocked at how impressive patients find it that you're sitting with them for a half hour and answering all their questions. You got nothing else going on. And this has to be a half hour distraction free, these consults. And these are not things that you do once a week on Friday when you're not seeing patients. These are things that you're doing every day, 20 minutes to a half hour. You might be doing 2 or 3 a day if you want to make sure that your schedule stays busy. Now, a consult could be done on another day, or let's say, you got 5 minutes left in that new patient's, appointment period. You've gone 55 minutes into it between what the hygienist did and your exam and charting. You got 5 minutes left, but let's say your next patient canceled or you have a half hour available. You could then ask the patient, hey, I could sit down and go over what I found with you today. Do you have any time? They go, yeah, as a matter of fact, I'm off today. Well, then fine. You take 5 minutes, you put the treatment plan together, you move them to your room, and you present it because you have time to do it effectively. If you don't have the time, don't start presenting the case. Again, look, you have to do what is real to you. This is your practice. You make the decisions. But one of the things that we instill in our clients very early is if you don't have time to close the case, don't start presenting the case. Because this is what goes wrong with the sales process in most dental practices. And you could apply this to recall appointments too, folks, because normally those you're only spending 5 minutes on, right, when you're in there for an exam. You have 5 minutes, you try to cram everything that's going on with this patient, this $8,000 to $10,000 worth of treatment that they need into 5 minutes. You don't have time to answer their questions. Sometimes it's coming to them as a shock. Then you send them off with the treatment coordinator. Then later that day, you ask the treatment coordinator what happened with that patient. Oh, they said they were going to think about it. And then where do they go? They go onto the incomplete treatment list, which, some people have this idea that the incomplete treatment list is like printed on gold leaf. It's not. You ask your staff. If they have an opening on the schedule and they pull out the incomplete treatment list, how effective is that list at finding patients to fill those openings? If you are the average office, it is not effective at all because all that incomplete treatment list is patients who are not closed on doing the treatment. Okay. They haven't accepted it. So it's, hey, Joe, I know 3 months ago, you told us you were going to think about this treatment plan. We have an opening today. Yeah, I'm still thinking about it, or I'll talk to you when I come in for my cleaning. Not super effective means of filling the schedule. Okay. But that's how the average office goes. So we're not going to do that. If we got 5 minutes left and you don't have time, a patient is being seated in the next room for you, or the patient doesn't have time, we're going to bring them back for a consultation. All right. Now, there's a way around this, which I'll talk about here in a second, but this is the average scenario. 1 hour new patient initial. We're now bringing them back for a consult. How might that look? Now, I've bullet pointed this for clients over the years, the various things you want to cover. Rather than going over the bullet points with you, I'll just give you what one of our clients actually shared at one of our seminars. It was great. And it's how he applied what we taught him. It's basically, you'd say something like, Mrs. Jones, we've gathered a lot of info today. This is when you know you're going to have to bring them back for a consult. There are a lot of things going on. I want to make sure we have time to do this the right way. I want to sit down with you with all the information we've gathered, the x-rays, and think about this and come up with the right course of action, what's best for you. If it's all right, I'd like to have you back here within the next 3 days, either tomorrow, the next day, or the day after, to sit down for about 30 minutes or more if you think you need it, and really go over it with you, answer your questions, and so on. Now, from the patient's perspective, they usually really appreciate this coming from the doctor. And if you want to add a little, caveat, not really a caveat, but a little bonus to this to really make sure this patient shows up, so you've said all this, and you might even say your assistant's there or the hygienist is there. You might even ask, hey, when is my next consultation appointment available? Let's say today's Monday. They go, well, doctor, we have one Wednesday morning at 8 a.m. So you might look at the patient and say, hey, I have an appointment at 8 a.m. on Wednesday. Could you be here for this at 8 a.m. on Wednesday? Sure, doctor, I could be here. Okay, good. Well, when you go to the front, they'll get you all scheduled. I look forward to seeing you. So now the doctor is helping to affirm this appointment. That's going to add a little bit more, steel to it to make sure that they actually show up. Now, occasionally a patient will ask when you say this, one of a couple things. Well, they might go, well, how much is it going to be? What is the treatment, doctor? Very easy to handle. Again, this came from our client, which I loved what he did. It's one of these things where you give bullet points, then you watch somebody go apply it, and it's just amazing what they do. He'd say something along the lines of, I want to wait a little bit to talk about it. I need to go over this, need a little bit of a time. I want to make sure I do this right, review it so that, I'm just going to blurt out what I found. I want to make sure I really take the time to do this right for you. And most patients really, really appreciate this. Okay. Or on the other side, and I've said this for years, what if the patient, you've done your exam and the patient says, oh gosh, doctor, do I have cancer? Well, if you haven't seen any indications of that, be truthful with them and tell them you haven't, right? I mean, be real with them because this is one of the things, just a pet peeve of mine, that I hate about medical testing. It would be like, go to the doctor, say, I have a headache. Okay, well, you might have a brain tumor. Let's get you a CAT scan. You're like, oh my gosh. So when can I get my CAT scan? 3 weeks from now. When am I going to get the results? 4 weeks later. So you go through 2 months worried that you're going to die and you find out that nothing's wrong. So if a patient asks if something is horribly wrong and you can truthfully, clinically, this is up to you, answer that is not, then tell them Give them the truth. Don't leave them on pins and needles, but don't get into the treatment plan. Because again, remember, the second you start explaining that treatment plan, well, you have 4 root canals and 6 crowns that I need to talk to you about. You've started the sales process. So don't get into it till you bring them back. All right. So now, when are we bringing these patients back? Look, you could bring them back whenever you want. Okay. You could have time built in however you want to build it in, but it has to be distraction-free time. You can't be being interrupted during a consultation. That's annoying. Doc, can you come do this recall exam? Doc, so-and-so's on the phone. You need to be uninterrupted when you're doing a consultation. So what I normally recommend with a client, unless they have really supreme control of their schedule, is to do these consultations first thing in the morning or first thing after lunch. There's a number of reasons for this. Number one, if you're slotting time for consultations, you will fill them with consultations. And obviously, you're not going to do treatment that you don't sell. Okay, number one. Number two, first thing in the morning is great because you have nothing else going on. So you're in your office, you haven't seen a patient yet, and here's your first 2 appointments are consultations, 2 20-minute consultations. Number three, and this is why I like morning consultations, is most offices try to structure their schedule where they're doing larger procedures in the morning, primary time. Well, let's say you do a consult at 8 and a consult at 8:20, and then your first primary time appointment is at 8:40. Well, what if that 8:40 patient calls in that morning and said they had a family emergency and they're about to get on an airplane, and you now have a 3-hour opening this morning? Well, there's an outside chance that one of those 2 consultations that you're doing, your 8 o'clock or your 8:20, isn't working today. And they came in to see you, they might be off or they could take time off, and they could start their procedure today. So you find out when you walk in that your 8:40 procedure had a family emergency, had to leave town. When you're sitting down with your 8 o'clock patient, you present the treatment plan and they accept it. You might say, listen, I just had some time open up this morning. If you want, I can do this now. In many cases, they'll say, well, great, doc, I'd love to start it right away. Instant service. It's great. And that can save your day. First thing after lunch is great because, again, even if you work through part of lunch, which you shouldn't, you're not distracted or harried or upset. You're running right into this thing distraction free and doing this consultation. And you want this time allocated for consultations so that your office fills them with consultations. And it's really an organizational point. And I'll talk about this more in the next episode. But let's say you have a really disorganized closet. 9 times out of 10, when the closet is disorganized, is not because the person's, sloppy. It's because things don't have a place that they are supposed to go. Okay? Like you have a supply closet in your office. I guarantee you, if it's well organized, the impression, or you may not use impression material anymore, you use a scanner, but your composite material goes here. Okay? Your gauze goes here. Everything has a place. That's organization. Right? Everything has a place and everything's in the place it's supposed to be. So the same thing applies to sales time. I have a place to put, here's this opportunity I have. I don't have time to do it now. Where do I put it? Oh, I stick it in that slot there on the schedule. Whether it's a new patient or a patient of record or a second opinion or so on. We'll talk about this more when we get into the sales process itself, but it's important to allocate this time, and it's important for the doctor to be part of the scheduling process to make sure that the patient shows up for this time, because usually the complaint I hear with consultations, if I've ever heard any, is that, well, what if the patient doesn't show up? Well, in most cases, they're not going to show up for 3 basic reasons. 1, you got too much into the procedures during the exam. 2, the doctor wasn't part of the process because the doctor helps to really reaffirm it. Or 3, you scheduled it too far out. You scheduled it for a week from now or 2 weeks from now. Remember, the patient is there. They have their attention on their mouth right now. We want to reward that focus and attention by seeing them as soon as possible. Last 2 points I want to get into on setting up this consultation, because again, this is not going to be some special thing that you're doing once in a while, folks. Remember, you're doing these every day. Last 2 points, though, that are important is during the process of setting the consultation, when you're doing that, the doctor's explaining, I found a bunch of things today I want to talk to you about, etc. And obviously, you're not going to do a consultation for 2 occlusal composites. That's, you need a couple fillings. We'll talk to the front and get you scheduled, right? You have to decide sort of when a consultation is justified. It might be a $2,000, $3,000, $4,000 treatment plan. In other words, you're going to need more time than the 5 minutes or 2 minutes that you have. But during that process, when you're scheduling it, when the doctor's asking, when's my next one available, whatever, this is where you make sure if any other decision makers need to be there, that they are there. So you're setting this appointment. You might ask your patient if they have a significant other or a spouse. Do you make decisions about your healthcare on your own, or do you normally like to have your spouse present? Because what you're trying to avoid is when you're doing the actual presentation for them to say, well, I got to talk to my wife or husband. You'd like to, head that off at the pass by having their wife or husband actually there. So let's say you were talking to me and I go, yeah, normally I have my wife there. I like to talk to her about these things. Well, then what might you do? Well, why don't we schedule for you and your wife to both come? Okay, well, maybe it might take a couple extra days to organize that, but then you've eliminated that potential objection. And as an added bonus, let's say my wife isn't a patient in your practice. Well, you might be able to get her as a patient. This is a potential new patient opportunity, right? And, look, we do this here at MGE. If I was talking to somebody about a training program and they go, oh, if I spent this money, my husband's going to kill me or wife's going to kill me, I don't do it because I'm not interested in creating problems for this person at home. I go, well, why don't we get them on the phone, or why don't we get them down here so we can talk about it together? Because I would like for them to have support in doing my training program. I don't want them fighting against, their home life to do my training program. I want everybody on board, in other words. Okay. So in this case, you might get a prospective patient out of it, and it also helps to affirm the close when the person is actually there. So I'm doing that when I'm setting up the consultation, number one. Now, number two, and we've had a few offices do this, a number of our clients, because part of the problem is no matter how good you are at this, you're going to lose some patients who don't come back for the consult. It's not going to be a lot; it should be well under 10% or 10, or less even if you're doing this right. But one thing you could do to avoid this altogether is you could try to schedule the appointment to the consultation, their new patient initial appointment, so that the consultation time is actually already built in. Now, in order to do this, there has to be a lot of skill at the front. And they have to really know how to use that new patient intake form. And so let me explain what I mean. So you're going to have some new patient initials, which would be an hour, and you're going to have some which are going to be an hour and a half. How would I make the decision as to which one this is going to be? Well, if you have a good new patient intake form, which again, I have a sample you can download that you just go into the episode webpage. But let's say a patient calls in and they say, yeah, I'm looking for a dentist. I haven't been to the dentist in 6 years. And you're asking them questions. Is there anything you'd like to discuss with the dentist? Is there anything you're looking for help with or that you want to handle? And they go, yeah, I'm missing a couple teeth. And, I have some pain on the upper right side of my mouth. So this person already is going to need some type of restorative work, potentially implants, and they may have some other kind of decay going on in their mouth. I mean, you can't diagnose it, obviously, the receptionist, but that this is not going to be a cleaning and a filling most likely. They're missing teeth, okay? So in that case, you'd schedule this person, their new patient initial would be an hour and a half. Because then they come in, they do their charting, their x-rays, etc. You do your charting, they get their x-rays done, the periprobing, etc. And then, that first hour is gone, but now you got a half hour to actually present the treatment plan to the patient. But this is where your receptionist has to have skill. Because let's say you can't quite tell whether this person might or might not. And again, you're guessing here. And, we're not a clinician taking this phone call, but you're guessing whether this person will need extensive or not extensive work. If you can't quite tell, you schedule them for an hour because you don't want to run the risk. And because what you don't want to have is your receptionist is just scheduling everybody for an hour and a half, and you walk into the operatory and there's an 8-year-old kid sitting in your chair for an hour and a half. You're going to be playing video games with them for the last half hour. You want to make sure that only a patient who potentially, because again, you don't know till they walk in and you look at them, might need extensive work, gets a longer appointment, but then that requires more skill at the front. I'm not saying it's unobtainable skill or even difficult skill to teach, but you want to do this right or it can backfire on you badly. All right, so now we're at the point where we're either presenting the treatment now or we're bringing the patient back and we're presenting the treatment, 1 to 3 days from now. So when we come back for next week's episode, we're going to get into the actual consult process with the treatment coordinator, the financial discussion and everything else as part of the sales process and the various component points or that we want to make sure are done to maximize our close percentage. Again, I hoped to fit this into one episode when I was designing it, but I think I've already exceeded my 30 minutes, so I don't think that that's very real. While you're waiting for next week's episode, you could look through the stuff that we've covered so far. You could listen to it even with your team and start checking off how you're doing this in your practice to see if there's ways that you can begin to improve. Anyway, that's all I have for you this week before I come back for next week. Don't forget, I have, I listed the downloads as well as the links for what I talked about this week on the episode webpage. I will see you back in next week's episode where we're going to get into the closing process and actually making sure that we retain this patient later. And if you want to find out more about MGE in the meantime, you can visit us online at mgeonline.com or call us at 800-640-1140. Folks, have a great week, and we'll see you at the next episode.